Good evening, and thank you very much to Med Chronicles for inviting me to give this webinar on behalf of the UCT Lung Institute unit and also representing the Real Pollen Count. Really what I hope to do this evening is to change the way you see your seasonal allergic rhinitis patients and to really consider all aspects, and I hope to empower you both as provider and also your patients to improve the care that you give and that these patients experience. Firstly, my disclosures here that I've received speakers or educational grants for. And then I think very important, and you'll see later, that we've done considerable work with the South African Pollen Monitoring Network. And this has relied on a lot of contributions from sponsors since its inception in 2019. And what you see on this page are a list of all people that have contributed and all industries that have contributed to varying degrees across the course of where we find, and hopefully many of them will continue to support our work to grow this network into the future, to bring up-to-date aerobiological monitoring to South Africans. So just the basics, allergic rhinitis is a very common problem that affects a lot of South Africans, estimated around 30%. Within the adolescent populations in certain areas. And of course, atopic diseases go together. And so oftentimes when you see allergic rhinitis, patients also suffer with comorbid asthma or other atopic dermatitis like diseases like atopic dermatitis. And here you can see that, asthma affects about 10% of the South African population. And in 70% of those patients, there's comorbid allergic rhinitis. Also, the data that we've done from various sort of survey-based questionnaires assessing allergic rhinitis suggests, similar to high-income countries, actually, that we are seeing a progressive increase in low middle-income settings in terms of the burden of this disease. And of course, all of the data from the Northern Hemisphere with respect to climate change is suggesting that we will see a continued growth, unfortunately, in the burden of allergic rhinitis and allergic diseases driven by particularly pollinosis, as in this picture. I think to start with, when one sees a patient with allergic rhinitis, there's some basic pointers. And I picked this up some years ago, actually, from a family physician journal. And I just find these points to be very helpful in the basic workup and assessment and thinking about the patient that's sitting in front of you with rhinitis. The first thing to say is that on the whole, the one distinguishing feature of allergic disease as opposed to infections, irritant rhinitis, vasomotor, is that as allergies itch. And in fact, antihistamines are the way to treat itch, and they only relieve itch. In contrast, though, most rhinitis that you see in front of you often is multifactorial. It's not just one factor driving it, and very common irritant rhinitis. So the normal function of the nose is to condition the air, to warm and humidify the air. And often the sneezing response is to get rid of irritants that one breathes in from the external environment. And with our anthropomorphic changes, with pollutants that we're seeing in the air, this is increasing. And the job of the work that the nose has to do is increasing. And treating that as allergic rhinitis does not work and will not relieve these symptoms. Then the other thing, of course, is that even though you might see somebody during the season and you might think immediately, oh, this is seasonal allergic rhinitis, in fact, respiratory tract infections are very, very common. Some data that we saw emerging after COVID suggests maybe every 6 weeks, people are colonized by a virus in their upper respiratory tract. And a normal adult can have between 3 and 5 upper respiratory tract infections a year. And then the look at the natural history of infections in the rhinosinus area, one sees that one goes through this full spectrum of often a 5 to 7 day illness. Patients can produce green, nasty mucus and nasal congestion. And these often clear without antibiotics within a 2-week period, and also are not necessarily allergic rhinitis symptoms, although they can coexist, as I'll show you in the next slide. Then the other thing, of course, to think about is there are other causes of facial pain. Headache is often, and migraine is often incorrectly or missed in the consideration of nasal symptoms. And then, of course, when one thinks about treatment and treating allergic rhinitis, if one gives isolated intranasal steroid, one sees that this actually often takes 2 weeks or more to work before it has a measurable impact on allergic rhinitis. And then, of course, two general allergy principles that I always like to highlight to a GP audience is that food allergy tests are not useful in the diagnosis of allergic rhinitis. And then the other thing is that, and this is often can happen, and I'll show you some sensitization data, some IgE profiling data. IgE profiles or sensitization and even skin pricks don't necessarily correspond directly with clinical allergy. So one is always needing to, when one's setting a patient, link up the clinical symptoms of rhinitis in relationship to exposure to specific triggers and match those with the results of your blood tests. This is something that maybe some of you won't be aware of, and I think is important in terms of considering patients in the season. And this is data here that you see, which is it's a graphical abstract that is looking at some in vitro work as well as some epidemiology work. And really what this is showing, if you look at the top corner here, this particular section here, this shows you that when you look at a group of nasal epithelial cells and you stimulate them concomitantly with pollen as well as rhinovirus, what you notice is that in the presence of pollen, you get a downregulation or a decrease in the production of local mucosal immunological molecules called interferons, and you get an increase in viral replication. What's this showing is that simply the presence of pollen against the nasal epithelium actually increases viruses if they're there and the ability to combat them. And this is correlated in the lower picture at the bottom here with epidemiological data that really showed that as the birch pollen season in the northern hemisphere increased, the epidemiology or the incidence of rhinovirus cases increased. So what's interesting and probably most interesting about this data is the fact that this is a non-atopic population. And what this is saying is that pollen may be contributing to the burden of upper respiratory tract infections independent of the population you're talking about. So the climate change impacts related to pollen may have broader implications even for the non-allergic population. But of course, this is important to consider because when you're sitting with a patient in front of you, the differential may of course be infections. So then the other thing in terms of differentials in considering your patient is that of other causes that are non-allergic, right? And so I mentioned that most patients you see have this multifactorial reasons for rhinitis, but I really think it's important to think about all of these. So think about irritant symptoms, to think about vasomotor. The vasomotor non-allergic rhinitis group, this is the group that is responding to your strong odors, your perfumes, your petrol, diesel fumes, with changes particularly in running of the nose, so rhinorrhea, and also blockage. Oftentimes, patients with complicated allergic or rhinitis needs to be assessed by an ENT, where you can see if there's any anatomical problems that are contributing. And then again, if you just look at the bottom of this table that I put here, you can see the itching that really is one of the hallmark features of allergic rhinitis. Then one of the things that I think is important when one's trying to assess, and more importantly, actually, when one's trying to manage a patient with seasonal or even perennial allergic rhinitis, is some way in which one can objectively monitor and have people themselves monitor the progress of their condition, when their condition is worse, and how it progresses with your treatment. And really, if one considers allergic rhinitis, there are four major symptoms that you're talking about. Nasal obstruction, how much blockage the nose is, how runny, rhinorrhea, how much running there is, and often this is related to postnasal drip, then itching and sneezing. And my own personal practice experience, although there are many complicated, very in-depth quality of life indices, complicated scoring mechanisms such as the SNOT-22, which is shown on the bottom here, my own personal practice is to use these simple visual analog scales. And what I do is I get people, when I take the burden of disease, to try to tell me on a visual analog scale between 0 to 10, how would they rate each of those symptoms with respect to their allergic rhinitis. And then often now this has been translated. We're living in that kind of digital age with a lot of apps There are many of these personal trackers for allergy symptoms that are available online and through the App Store. This is one I just found when I was looking at them last night, and it does pretty much the same thing. And what this allows is people are able to track their symptoms across the season, okay, and also bring this report to you, and I'll show you the importance of that in subsequent slides. Then how do we broadly consider a patient with, now one's pretty sure they've got triggers that suggest environmental exposures, they've got those allergic rhinitis features related to itch. How do we broadly consider where they fall in relationship to, you know, how much time do we want to spend investigating this, how much do we want to guide them, and what's going to happen in terms of our management strategy down the line? So really you can consider intermittent symptoms or persistent symptoms based on the top two figures here. And normally what you'll see with seasonal allergic rhinitis patients that are only sensitized to those seasonal allergies is they will have intermittent symptoms or a period of time where they have persistent symptoms across a few months of the season. And then generally we divide it into these two groups of mild and severe. And really mild patients have very minimal impact on their quality of life, whereas severe patients have disturbances in several domains. They have disturbances in sleep, impairment of their ability to do their normal activities, particularly outdoors, and then often absenteeism and time off work and school and troublesome symptoms. And of course, there is also a synergy, although I showed that figure about viral illnesses related to anybody in the experiencing pollen in their nose, there is a recognized synergy between uncontrolled allergic rhinitis and respiratory tract infections. So these patients with uncontrolled disease are also getting respiratory tract infections, which is driving time off work for them. Then what about the sort of overall, if one considers all aero allergens as a group that are driving rhinitis? What you see here is some data that's now quite old from the 1990s, but really the pattern here has not changed even over several decades. And what this shows you is a bar chart which highlights the number of positives in a cohort of patients with allergic rhinitis. And you can see here that house dust mites as a group, okay, are very important perennial allergies. These are indoor allergens. And then the things like cat and dog dander, we also see cockroach increasingly as an issue, and molds. And then one sees the next big group as the pollens. And there you can see that grasses stand out as an overall group, but there's not insignificant burden of tree disease as well as tree-driven pollenosis and also weeds. And then another important thing that can improve your management and your care of patients that experience seasonal allergy symptoms is recognition of cross-reactivity that occurs between certain proteins in pollens and particularly their homologous proteins or allergens in fruits, nuts, and other vegetables. And what you see here is a list of the common and well-known what we call pollen food syndromes. And these are best described, for instance, for patients that are primarily sensitized to PR10 or profilin proteins in birch. And when they ingest rosacea family fruits, they experience oral symptoms, particularly itching and often some mild swelling of their tongue and upper mouth area. And interestingly, when they swallow and these proteins are digested, they don't get any kind of systemic allergic responses. And that because these group of homologous proteins that are found in pollens and in fruits and vegetables, they are what's called heat labile or easily denatured. And we see several of these, and oftentimes patients are very impressed with you when you ask them, do you experience symptoms when you, or tingling of the mouth when you eat raw, to certain types of raw fruits and vegetables. And what's interestingly is actually just taking a good history, you can often tie them to their primary sensitizing agent. Like you can see here, the group linked to birch. There's a group linked to the weed pollens of ragweed and mugwort. And then there's a group at the bottom that's linked to cross-reactivity with grass pollen, allergens, and melons, certain melons. So these are a nice group of questions in relationship to patients experiencing seasonal pollenosis that links to particularly sort of quite mild but inconvenient symptoms related to pollen food syndromes. And then just to say what's fascinating is I get people telling me about a complex picture. So sometimes people will say they will eat an apple and some apples will cause them a problem, and then another time they eat an apple and they have no problem. And what this is related to is that as fruits change, so do the amounts of various kinds of proteins that are allergenic. And further than that, not just do they change across how, for instance, ripe they are, or the state that they are, but also between different cultivars or different varietals. And that's what I love about this particular study. This study is looking at the major profilin in apples, which is called MALD1. And what they're showing here is this graph at the top is showing the skin prick test responses to, look at this, is almost 25 different varietals, 23 different cultivars of apple. And in this corner here is birch, which is the cross-reacting molecule. And it really shows you how the level of allergenistic, or the presence of the allergenic proteins, varies across these different cultivars. And actually this study is further interesting because what they were actually trying to do in this study was use, and this is the picture cartoon on the far right, is they were trying to use this potentially as a form of oral immunotherapy by using a low allergenicity group of apples to change the profile of patients to both their reactions to this MALD1 allergen as well as to their pollen birch B1. But this shows you the range and also the complexity in trying to sometimes tease out these pollen food syndromes that you experience. So what about the patient that you now are pretty convinced is having a seasonal allergic rhinitis? What can you offer them that is more than just what you may be used to, which is just take a nasal steroid or take an antihistamine? And why should you do that, I guess, is the question. Well, the first thing to say is that if you're looking at pollen levels, you see considerable season-to-season variability, which is largely driven by short-term meteorological factors. There's obviously climate change driving change across decades, but this refers to kind of year-to-year variability that you see. If you just look at, for instance, in Cape Town, we've seen over the last couple of years huge differences in the winter rainfall. A couple of years ago in 2017, we had a drought. So just in the short space of years, we see quite a lot of change. And this makes a significant difference on our season-to-season patterns for pollen levels. And these figures highlight this, right? We took 4 years from 2011 to 2014. And really all that we're showing you here is the shape of the pollen season across the critical months, usually from the beginning of spring or late August through to December, January. Here you can see in 2011, we had this dual spike. In 2012, we had a kind of single season. 2013, considerably different in terms of the height of that season. And this definitely, we see, this is reflected in antihistamine sales in pharmacies across the country. This is reflected in how many patients contact you actually are not bothered by their symptoms, because in a particular year, we can see a 2-3-fold difference. And the major driver of this, as I mentioned, is local weather patterns. And in fact, climate change is driving the frequency of extreme weathers. And we really saw the impact of this highlighted in the Cape Town drought. So if you see this in 2017, this is a figure on the right that shows the total amount of what's called the annual pollen index. Okay, and this is the annual pollen grass index that's been charted here. And really what you see is how, again, season-to-season variability. During the drought years of 2017, we saw very, very low annual grass counts. And then when the rain came in 2018, we saw this massive spike. So this was the highest recorded peak of grass pollen in a decade. And certainly in 2018, we saw a massive flux of people contacting us for treatment in relationship to their grass pollen allergy. Then what about the geographic region across South Africa? So South Africa is one of the most biodiverse countries in the world, and in fact, we get onto the megadiversity in diversity in general across the whole animal and floral kingdom because of our own floral kingdom that occurs in the Cape floristic kingdom related to fynbos. But actually across the country, as this map illustrates, we see these different what we call biomes. And the biomes have got very unique background vegetation, and this obviously is important for environmental exposures. The South African Pollen Monitoring Network has been monitoring since 2019 and in 7 of the major urban centers of South Africa. We recently published this data in Clinical Translational Allergy, and if people want more details of these, we go into extreme amount of detail for each of these cities, and it's worth checking out. But primarily what I wanted to highlight here is the fact that these cities represent and situated in different biomes. They have quite different climates, right? So on the Highveld, we see a summer rainfall climate. In the Cape and along the coast, we see winter rainfall. Of course, the populations also differ, which affects the total number of people that are suffering. What's the relevance for where you live in the country? Well, depending on what you're allergic to in terms of the season, this can make a huge difference. And what you're seeing in this grant are just looking at, again, the total burden of certain types of pollens that we see year to year. So really the tree capitals of South Africa are the largest urban forest, which is often, Joburg is often referred to this, but we see also very high levels in Bloemfontein and Cape Town. If you're talking about grasses, and that's your major problem, well, really the region of the Northern Cape and the Free State are the leaders in terms of grass pollen allergic levels across the year. And you can see that some cities, particularly on the coast, we see very low levels of grass pollen. And so if you're a grass pollen allergic person living in Durban, this is probably not such an issue for you. And then lastly, weeds are another important group that we see kind of leading the way, also Cape Town, Joburg, but Durban, for instance, which is not very high on grasses, we see substantial weed pollen levels, and certainly this could make a difference to particular groups of allergy sufferers. If you look at the actual absolute levels, again, I think this is important. What we see here is that for trees and weeds, it's sort of reflecting very similar data to the last slide. We see these very high levels in Joburg. If you look at Cape Town, we see kind of moderate levels of all three. And you look at Bloemfontein, what really stands out there is the grass, as is Kimberley. So this gives you an idea of total levels. Interestingly, if you compare us to the Northern Hemisphere, what you see is that we actually have probably less than 6 weeks of the year where our levels go into the very, very high range, above 100 grams per cubic meter. And this is in contrast to places in Northern Europe, which will have several months, actually 3 or 4 months, where these levels experience. So actually, at the moment, we do not sit in the Southern Hemisphere. We sit quite distinct from our Northern Hemisphere colleagues. And certainly pollinosis that they see is probably more severe than what we are seeing in the Southern Hemisphere. And what about tree pollens? I think this is very important in terms of different types of trees that can be driving symptoms. And that's really what we're showing in this graph. So this is, the colors are matching the different biomes and the cities. And you can see, we see quite a range. We see cypress as a very important, and plane tree as a very important two trees that we occur across the country. But then in different cities, we see more mulberry, more olive, more birch. What you notice about all these trees is the allergenic trees are largely northern elemental trees that were planted in South Africa. In fact, the burden of endemic tree pollen allergy is estimated to be very low, with most, and for instance, the same is true of fynbos as causing allergy. And this is often related to the fact that these pollens are heavier and they tend to not really be distributed very much on the wind and hence get very little into people's noses and cause problems. So I think this is an important thing when you're considering the tree pollen picture. What about the total exposure to certain seasonal allergens? Well, this series of graphs really shows the quite sizable difference in the grass pollen season shapes in different parts of the country. Really, for grass pollen allergies, you want to be in the coastal cities. Cape Town, we do see quite a significant peak in October, November, but certainly in the Northern Cape, Free State, and then on the Highveld, what you see is significant levels of grass pollen all the way that often goes out into April, May. And if you speak to people that have suffered with or do suffer with grass pollen allergies, they will often report this if they travel around the country very clearly. And then what we have looked at and what we try to produce for the 7 cities, and we've done this, and these are available if people are interested in tracking these down, is we have pollen calendars that actually look at each city and try to detail out specific dominant allergens in terms of pollens. And this one example I'm put on here is for Cape Town. And the reason I put this for is to show you about how the different timing of the season is important. And often if you ask people a little bit more detail, you can get a good idea what particular pollens they're allergic to. So for instance, here what you see is the trees. So this is cypress tree here, pine tree, which is in August, and then we see mulberry trees sort of across the year. But particularly cypress tree and plane tree, here's plane at the bottom, we see in a very short space of time, quite in the late winter, early spring. So this is actually July and August. This is not typically what we would be familiar with now in September, October. In contrast, if you look at the grass pollen season, this comes later, more like October, November. That's the peak of the season with a little bit of a tail. And then actually, if you see that weeds tend to come in the later into summer and not really be significant allergens in the early parts of spring. So just actually taking some detailed history allows one to quite nicely tease out what people are likely to be allergic to. We put these into calendars that are more user-friendly for people. And as I mentioned, please feel free to reach out to us so that we can provide you with some of these calendars. So how does this translate? That might be the pollen data, but what about the other side? Now, if you actually test people and you look at their sensitization patterns, well, what we see is this data here is from the last 5 years of our multi-component ALEX testing. So we've tested over 600 patients presenting to our allergy clinic, including, well, predominantly the older groups over 12 years old, but we do have a small group of children. And what we see here is a significant burden of pollen allergies. You can see here, this is 186 patients and 48, we had 2 different versions of the test. So all in all, about 220 out of 600. So that's close to, over a third of patients that have some form of tree pollen sensitization. The rate for grasses is even higher than that. And then wheat pollens, it comes in sort of third place, but not insignificant. And you can see here, remember I showed you those pollen food syndrome things. You see mugwort, you see ragweed. Here in terms of the grasses, we see the common grasses like Bermuda, rye, and Timothy grass. Timothy's at the bottom. And then trees, we've already mentioned cypress, plane, oak, mulberry, and we still do actually see small amounts of birch and even olive tree in the sensitization patterns. If you look in another part of the country, this is data from Maria Cedas's group in ENT clinics in Bloemfontein. Here you can see exactly what I showed you right in the very beginning, the overall distribution of error allergen sensitizations. You see house dust mite just eking into top position ahead of grasses, but then not insignificant amounts of trees, weeds, and molds driving symptoms. And here you see a breakdown at the bottom of tree pollens, and importantly, a good spectrum of allergens, but noticeably some interesting local factors driving specific tree pollen allergies. And here you see quite high levels of willow and poplar in Bloemfontein related to specific stands of these trees that have been planted across the history of those cities. So one of the reasons that, I've shown you quite a lot of variability, quite a lot of differences in different parts of the country. Now, we like to think then that we can individualize the care of our patients, and we can do this really in 2 ways. The one is by providing patients with the real information, and of course, as healthcare practitioners, you can also access this. And so we set up the real pollen count, which is at the website there I've listed at the bottom, pollencount.co.za. This is now the biggest pollen website in Africa. During the season, we get about 20 to 30,000 hits on the website. And what we do on this website is we post the weekly pollen counts, and we give an overall pollen index, and then we break it down by grass, trees, weeds, and molds, and we give it per city. And what we use is something called a traffic light system. And a traffic light system is really simply putting colors to numbers which are less user-friendly. And then what we do is when the pollen counts are green, that tends to mean they're low and that people should not be concerned. And they go up through yellow, orange, red to dark red, indicating increasing amounts of likely clinical symptoms for people that suffer with those kinds of allergies. And really, many people have reported. Just yesterday, I had a patient contact with a nice email saying how being able to follow this pollencount.co.za has really changed her life in terms of dealing with her symptoms. So it really can have a direct impact on people's experience about when they should wear their mask, when they should spend time outdoors. And for instance, I mentioned like the tree pollen season for plane trees is actually very, very short and very intense, possibly 3 weeks a year. And if you have just isolated sensitivity to plane, just curbing your behavior just for those 3 weeks will make a difference to your overall symptoms. And then after that, you can go about your business. Often people follow that count in terms of when to start their prophylactic treatment or their intranasal steroid. They use the changing counts and the slight rise to signify that they should start their treatment. The other thing that I think is increasingly being utilized and people are really enjoying is citizen science endeavors. And this is because sometimes there could be a plant or a pollen that is causing irritant symptoms for patients. So they're not picked up on your tests, but these patients say, when I am in this part of the neighborhood or when I drive to this area, I get these symptoms. And what I encourage people to do is use these citizen science efforts to help them identify it. So the one I particularly like is this iNaturalist app. How this works is literally if you're in a particular area and something is causing you symptoms and you're worried what it is, you can take a photo of it. Usually you need to take a photo of the flower or these things. You post it. The AI gives you a recommendation of what it is based on your geographic coordinates. And then afterwards, people across the world or locally confirm or refute that identification and give you an update. And just using that, I've had people come back and say to me, you know what, I found out that it's this species of hawthorn that flowers during this time that causes me to have irritant symptoms. And I know where these stands are and I can avoid them. And just doing that, you really empower patients to take care of their symptoms. Then how does this relate, all the data I've shown you, how does this relate to sitting in front of you and deciding what patient, what testing profile to use? So this is from the Allergic Rhinitis Working Group of South Africa. We published this statement on several aspects of rhinitis care in this SA Family Practice last year. And this was our suggested panel testing for patients that had suggestive symptoms of allergic rhinitis as our screening. And here what you can see is it's got it covers all those common aero allergens I was talking about. With respects to pollen, it covers Bermuda and rye because often people can be either sensitized to Bermuda or rye on their own. So it's worth testing for both. And then in terms of our trees, over this South Africa, we find that the commonest allergic sensitization patterns and pollen exposures are for plane and cypress. But what we do here, you can see we put a little footnote here. And the footnote really just says that ideally people should refer to the calendars and understand the regional climate that they are working in to guide their patients. So although we're using that here, we are really suggesting to people that they get more granular to be able to care for their patients. What about allergic rhinitis care? So now you've done all the recognition of it. You've tried to help people define how could they change their behavior, what are they actually allergic to, and then what about now managing it in the best way? So again, we have published this algorithmic approach, which is aligned with several practice parameters from the European Euphovia group, as well as the Quad AI American Academy in terms of their practice parameters. And it's really got a stepwise approach. So the first step is in a treatment naive patient, one uses first line approaches, which can be either continuous use of intranasal steroid. You may or may not use an additional oral antihistamine. Some patients actually prefer just to use a isolated oral antihistamine. You then should reevaluate those patients, and this is where the use of those monitoring tools, the visual analog scales here come in. I'm going to show you some slides to end with on immunotherapy, but this should be considered. If you want to then step up therapy, we recommend checking the basics always: nasal spray technique, adherence. Are they following the pollen count? Are they aware of the exposures? And then what we have been fortunate enough to have in the last couple of years coming into the South African market are combination intranasal sprays that combine an intranasal antihistamine with an intranasal steroid. And the great advantage to these is these offer people immediate relief from a spray, and often people feel frustrated for the reason when they use an intranasal steroid alone, it takes 2 weeks before it has any effect. So there are now these sprays available, and we would recommend them at this point. And again, we recommend following up and reevaluating. And then there's several other kind of more complex approaches that you can consider to deal with patients whose symptoms are not ideally controlled. What's quite nice is also to have a reference like this when you're counseling and talking to patients, because what this shows you here is the set of different treatments available for allergic rhinitis, from oral antihistamines, intranasal antihistamines, ocular antihistamines, steroids plus antihistamines. Decongestions are also important here. And what is highlighting is which specific rhinitis symptom these treatments best target, and also telling you in the side here the particular advantage in terms of onset of action. And I think this is really important for counseling your patients. How will they experience these treatments, and what should they look out for? And why, if it looks particularly at these new products of these combination therapies, the intranasal and antihistamine combinations, what is the particular advantage of having them in a single device? So the first is relating to the time of onset, right? This faster action of onset with the intranasal antihistamine. These things really do improve compliance and adherence, okay? You then get, in addition, the long-acting anti-inflammatory effect. And then, it also, some of them have different amounts of controls in comorbid allergic conjunctivitis. And the costs vary depending on what particular combination of steroid or oral or antihistamine you're using. But this is something that you've got to consider in terms of both the number of sprays and also the combination costs of different therapies. Finally, I want to end by talking about immunotherapy. What's interesting about immunotherapy, allergen immunotherapy, is firstly that across allergic rhinitis, both subcutaneous and sublingual forms of immunotherapy have got a grade A strength of evidence. So they are well-established and well-established effective therapies. What can you hope to get from allergy immunotherapy for allergic rhinitis, and who should you perform it in? So what we recommended is in patients as add-on treatment for your allergic rhinitis patient that's got uncontrolled disease, despite some of those first-line and second-line therapies that I've talked about. There's lots of meta-analyzed data to show the benefit of these in randomized controlled design. But what are the benefits that you can expect? The big problem with it is it's 3 years of therapy, but you can expect to get reductions in your symptoms, reduction in medication use. So over the long term, this can actually prove to be cost effective. And then actually there's some lovely data that you might prevent the progression of different sensitizations or worsening of other type 2 inflammatory conditions with the use of allergy immunotherapy. Now, coming back to the importance of defining your patients and trying to identify which particular seasonal allergies they are allergic to, also comes back to allergy immunotherapy. Because unlike those treatments like intranasal steroid or antihistamine, allergy immunotherapy is antigen specific. It only works for the particular antigens that you have in the mixture of sublingual or subcutaneous immunotherapy. And here, this is, just ignore the prices because these are a little bit outdated, but I put this in red. These are sublingual sprays to show you how we have combination sprays, which consist of multiple grasses. We have those that only consist of Bermuda or only rye, and then we have certain trees only. And so therefore, it's very important when you decide on a patient for allergy immunotherapy to really understand what's triggering their symptoms and what's their sensitization pattern, and understand the burden of disease relative to treatments down the line. This is the problem that we experience with grasses. So I've shown you lovely data from light microscopy pollen monitoring networks like ours about the different tree species. And we can very nicely, some specialist aerobiologists can very nicely identify individual species of tree pollens. The big problem that we have with grass and grasses is that light microscopy methods that we are currently using are unable to speciate grasses effectively. And why is this important? Well, if you look at our sensitization pattern, so this is coming back to the 600 patients that I showed you earlier, what we see is that a considerable number of our patients are sensitized to only Bermuda or only rye or only Timothy, right? So you can have, although there's cross-reactivity between certain grasses, Bermuda and rye are not cross-reactive. And hence, I showed you in that last slide, when you give immunotherapy for grass, if you're allergic to both of those, you need to give immunotherapy for both. Furthermore, because we can't speciate in our pollen traps and our pollen monitoring, it's difficult to see and know. In fact, we don't know when is the Bermuda grass season, when is the ryegrass season in different parts of the country. And so for patients in terms of allergen avoidance, we can't give them that level of granularity that we can for certain other exposures. And of course, this is limiting. We're trying to deal with this problem, though, globally as a scientific community in aerobiology, but also locally. We've made our first steps into doing this. One of the master's students in my unit, Sia Sindler, she's now completed her master's project to try to use DNA barcoding from our spore traps to identify these different species of grass. We've managed to successfully do this in our pilot. And now over the coming years, we will look to try to create grass pollen maps across South Africa. And I think this will be particularly useful for patients getting granularity on what species of grass they are allergic to. So I hope that in this webinar, I've now been able to take you through some both clinical applications, some aerobiological exposure, intricacies, and then some treatment considerations for you. And really my take-home messages are that rhinitis is usually multifactorial, and you must consider non-allergic causes, even typically when patients present in the season. If you're looking specifically at pollinosis, it's much more complex than just treating everybody with seasonal allergies. And what I would recommend to do is get to know your area, get to know your season timing and your local fauna that's in the area. And then empower your patients. We've got website, we're publishing the data, get people out there using it, recommend to people to visit our pollen count, and then feel free to drop us a line and collect one of the pollen calendars. And then also in terms of treatment, don't just consider intranasal steroids, right? We've got an increasingly excellent armamentarium to treat allergic rhinitis, including combined intranasal antihistamine and nasal steroid sprays. And then consider people that aren't having success with that, consider them for allergy immunotherapy. And there's centers in Joburg and Cape Town offering this therapy, and we can direct you to that, or the Allergy Foundation website can do the same. Thank you very much for your time, and I hope now you will go out and you will individualize the care of your seasonal allergic rhinitis. I'm stopping now and I'll take questions. Thank you very much.